Welcome, dear learners. In the last class, we completed the legal aspects of toxicology. Under that, we learned different acts, penal codes, and finally, the legal responsibilities of a doctor in case of poisoning. From today onwards, we shall learn the management of poisoning. This unit basically deals about the general management of poisoning. Regarding the specific management to a particular poison, we shall be taking along with the respective poisons classes. Medicine is an ever changing science. A new research and clinical experience broaden our knowledge that changes in treatment and drug therapy. So, accordingly, we have to improve as with the time and change our protocols. With this quote, I will emphasize that we must adopt the latest advancement of knowledge for betterment of the patients. According to World Health Organization, suicide is the fourth leading cause of death among those between 15 to 29 years of age. In India, suicide has become the number one cause of death among those aged between 15 to 29 years. In the past 3 years, the suicide rate in India has increased from 9.9 to 10.4 per lakhs of the population. The most common method of suicide in India was estimated to be hanging, amounting to be 54%, followed by poisoning 26%, as per the 2019 data. In the practice of medical toxicology, an immediate attention to the assessment of airway, breathing, circulation, and decontamination plays an important role in addition to assessing and monitoring the overall status of the patients. The vital signs are the essential part of initial evaluation of every patient, and frequent monitoring of vital signs are necessary throughout the subsequent management, which is the key to the successful management in critically ill patients. So, the looking for the vital signs and stabilizing those signs are the essential part of the management of critically ill patients if they are of the toxicology sides. The supportive measures should supersede all other considerations in management of poisoning patients. All poisoning patients will benefit from an organized, rapid clinical management plan. Once the airway, breathing, and circulation are addressed, the focus may switch to confirmation of the toxic ingestion and specific management issues based on the toxidromes. The treatment goal of the poisoning patients are supportive measures as mentioned above, prevention of further absorption of poison by the stomach wash, activated charcoal, and administration of antidotes. Further, the prevention of reabsorption by intrahepatic circulation of the poisons by the gut dialysis. Multiple doses of the charcoals are administered to prevent from the intrahepatic circulation poisoning. Skin contamination and enhancement of elimination of poisons by cathartics, whole bowel irrigation, dilution, forced alkaline diuresis, and extracorporeal removal of the poisons. Often, the history from the accompanying person, such as family members, friends, prescribing physicians, gives the clue to the diagnosis. The physical examination should also include evaluation of the head trauma, focal neurological deficits, neural tract marks, unusual odor from the patients, and auscultation for the lung signs. By the large, an overall comprehensive team approach is required to bring down the morbidity and mortality in toxicological emergencies. With this quote, we shall start the broad guidelines in the treatment of poisonings. The broad guidelines in the treatment of poisonings are: first step should be immediate resuscitative measures. So we have to stabilize the patient. We have to check all the vitals, all the ABCD, airway, breathing, circulation, and the CNS depression shall be checked, and that shall be prevented or managed. Then once the patient is stabilized, then the removal of unabsorbed poison from the body shall be the next step, so that the unabsorbed poison don't get further absorbed and produce further toxicological problems. Removal of absorbed poison from the body. Thereafter, the different steps has to be used that can remove the absorbed poison from the body. Further, the administration of antidotes shall be the approach, where the based on the type of poison we are using the antidotes, and many times universal antidotes are used for the unknown poisons. Then the symptomatic treatment according to the toxidromes approach, and then we shall be doing adequate follow up once the patient is stable and out of the danger, and thereafter the nursing and psychiatric care are equally important for the better care of the health of the toxic patients. So if a patients in a poisoned condition or with a suspected case of poisoning presents to you, then you should first look at the vitals, stabilize them, then take the measures so that unabsorbed poisons get removed from the body before further getting absorbed. Then the step should be to remove the absorbed poison from the body, followed by administration of antidote. Further, identifying the toxidromes and manage the patient accordingly. And once the patient is out of the danger, then adequate follow-up, nursing and psychiatric care is necessary. Under the immediate resuscitative measures, the first step should be that remove the patient from the poisonous environment. Wherever the patient is, immediately take out the patient to the fresh air, and then to the hospital, and where the patient shall be followed for the management of their airway, breathing, circulation, depression of the CNS, and finally re-evaluate the patient and look for the other problems. So, under the management, this is the ABCDE of the resuscitation that are often taught in the basic life-saving skills and the advanced life-saving skills. So, learning of the emergency care, learning of the advanced life care skills are very helpful in the practically in the management of the poisoning cases. And this ABCDE of the resuscitation has a very major role in the management of poisoning. Now coming to the management of the airways. Symptoms of airway obstructions that patient will present with the dyspnea, difficulty in breathing, difficulty in respiring, then there may be the air hunger and the hoarseness in the voice. These are suggestive of the airway blockage. Signs that you should look for are the stridor, that is on auscultation there will be crepitatory sounds or the a typical sound from the lungs. Then intercostal and substernal retraction that should be looked upon after the removal of the clothes and looking for the chest retractions. Then cyanosis might be present, that is the loose discoloration of the nails, face due to the inadequate supply of the oxygen. Sweating might be there, and the increased respiration, tachypnea are suggestive of the airway blockage. After you have checked for the signs and symptoms, then you should assess for the protective reflexes whether they are intact or they are inadequate, like cuff reflexes. And you must check the oxygen saturation continuously with the pulse oximeter. Also, that is on the ICU monitor, that is labeled as plethysmograph is the name for the pulse oximeter. So once you have these all details, that pulse oximeter, ideally the oxygen saturation, that is SpO2, shall be more than 95% for a healthy patient. Once it is lesser, then we may need to take the adequate measures. So if it is inadequate, then open and the clean airways. In this step, you should remove the dentures if the patient is using any dentures. Then use the chin lift and jaw thrust. So to clear the obstructed airway by the tongue falling the back. So jaw should be lifted, body should be in the supine position, or preferably on the left lateral or the right lateral position, and then the chin should be lifted up and jaw thrust shall be used to push the tongue in a right position so that it will not be blocking the respiration. Then remove the secretions, saliva, vomitus, blood, and others from the oral cavity by the suction tube or the finger sweep methods so that it will not obstruct from the respiration. Place the patient in the semi-prone or lateral position. It will help in the creating the adequate space in the airway. Then after, if still the patient is not showing improvement, then endotracheal intubation may be done. That will allow the clearing of the airway and the proper improvement may be observed. Still, if the improvement is not there or blockage it at the level of the trachea, then the tracheostomy shall be done, and this will bring out the proper airway of the patients. Further, once the airway is clear, there is no blockage of the airway, then you have to still if there is a not proper oxygen saturation, then there could be other reasons like the breathing shall be noted, the respiratory rate shall be noted, and the normal normal oxygen delivery requires the adequate hemoglobin oxygen saturation, adequate hemoglobin levels, normal unloading mechanism, and adequate cardiac output. So if the airways are not blocked and still the oxygen saturation is coming down, then it is suggestive that there can be inadequate hemoglobin saturation. That could be due to low hemoglobin, that could be due to low unloading mechanism of the oxygen at the tissue level, or inadequate cardiac output. So we must manage that thing in other part of the resuscitative measures. Then for the management of the breathing, you should look for the adequate tidal volume and minute volume using the respirometer. So in case of adequate not in ventilation like diaphragmatic paralysis or like that, tidal volume and minute volume may be disturbed. Then perform the arterial blood gas analysis for the acid-base balance. This is the important and very helpful step in the resuscitative measure in the emergency cases. Then perform the capnography to monitor the partial pressure of the oxygen. This all will help in the diagnosing the different types of acid-base imbalance in the body. So this is the in order to monitor or the tidal volume and minute volume, the right spirometer is used. This is the picture of showing the right spirometer. So the person, in casualty or in the ICU room, you may find this monitor, or in the pulmonary department of your institute, you may find this monitor, a spirometer, where the patient breathes through the mouthpiece, and then the computer plots the changes of his breathings, and this way the graphs of the respirometer is presented. As you can see in the picture, this is the tidal volume, that is the normal amount of air exchanged in the breathing when at rest. Then there is the maximum exhalation, that this graph will go up to this level. Still some air is remaining in the lungs, that is called residual volume, that is the amount of air that is left in the lung after the maximum exhalation. And then the maximum tidal volume is the once during inspiration, that this will raise to maximum level, that is the maximum tidal volume, and thereafter this is on the normal breathing. So this range is the total lung capacity of the person from the maximum inhalation to the remaining this residual volume. Normal tidal volume in an adult is around 500 ml, that is 7 to 8 ml per kg. Minute volume is the volume of air that is breathed into and out of the lungs in 1 minute. So to calculate minute volume, we must multiply the tidal volume with the number of breaths per minute, including both inspiration and expiration. So suppose a person is of, we have to calculate the tidal volume. Then we have the minute volume, that is we have to see the minute volume equal to tidal volume multiplied by the both inspiration plus expiration total count multiplied by tidal volume. So this will be suppose a person is having the 500 ml of the tidal volume, then and the respiration of around 12, so the minute volume will be around 6 liter. So in a normal healthy individual, this minute volume shall be but 5 to 8 liters per minute in a healthy individual. So if this is one of the good indicator in the toxicology or in the poisoning cases or emergency management of the cases where the respiration has to be checked, then if minute volume of a person is coming more than 4 liter per minute, then it is considered adequate and there is no need of the ventilation on the person. So with this, by spirometer, we can calculate the minute volume and the tidal volume. However, it must be kept in mind that ventilatory functions can fluctuate at any time. So regular monitoring of the patient is essential. Even if the person is now currently showing more than the 4 ml per kg of minute volume, but he may deteriorate at any second. So regular monitoring of the patient is essential. So the patient who is in the ICU or presenting in the toxicological emergencies, in those cases, a monitor shall be attached with the patient. And you must know how to read the ICU monitor or the cardiac monitor that is placed on the bedside of the patient. That is very helpful in management of the patient and the managing the vitals and all the things. So you must be able to read the indicators that are shown on this ICU monitors. You can see this is this is for the ECG graph that is shown. This is the heart rate, that is big. This is the heart rate indicator. This is the SpO2 99, and this is the plethysmo graph, that is a pulse oximeter graph of the oxygen saturation from the pulse. Then this is the partial pressure of the CO2 on the expiratory or endotracheal tube, and this is the capnograph, that is the changes in the capnograph is also of the vital importance. That may help in the diagnosis the different types of acid-base imbalances. Then this is the partial pressure of the oxygen. This is the ECG charting that is attached with the showing on the patients. And then this is the respiratory rate of the patient. This is here is the blood pressure of the patient, and here the systolic blood pressure, average of the systolic blood pressure. Here the temperature charting is there. So different types of monitor may have slightly variation, and you can even set the monitors according to your convenience in the ICU settings. After that, once the airway and breathings, the saturation has been checked, then after you should look for the arterial blood gas analysis. Arterial blood gas analysis is indicator of the acid-base balance in the body. Acid-base balance is affected in many poisoning. Arterial blood pH is maintained within the narrow range of 7.4 plus minus 0.3. So this is the normal arterial blood pressure of a person. Failure to uphold this level can have a bad results. blood pH value less than 6.8 and more than 7.8 carry a profound risk of the death to the person. Metabolic acidosis is said to happen when the serum bicarbonate concentration is less than 24 milliequivalent. And metabolic alkalosis is said when the serum bicarbonate concentration is more than 28 milliequivalent. This occurs as a consequence of either gain of bicarbonate or loss of the hydrogen ions. So in those cases, the metabolic alkalosis will result when the bicarbonate has been gained or there is a loss of the hydrogen ion that results in the alkalosis. And the acidosis, the reason will be the vice versa, that is increase in the hydrogen ion or the less of the bicarbonate ion. Conversely, a gain of hydrogen will cause the metabolic acidosis. Respiratory alkalosis is diagnosed when the partial pressure of the carbon dioxide is less than 36 mm of Fg. Respiratory acidosis is said when the partial pressure of CO2 is more than 44 mm of Hg. So respiratory acidosis, that is pointing that the patient is unable to respire. So concentration of CO2 in the lungs is increasing. So that is the causing the acidosis in the patient. And alkalosis is seen in the hyperventilation where the less of the CO2 concentration is there. So the acid alkalosis features will be produced. So we must know how to read the arterial blood gas analysis and according to interpret our finding that it is a metabolic acidosis, alkalosis or acidosis, like that. Many in the patient, usually this is presented with the combination of the features like respiratory alkalosis with metabolic acidosis, and the body, once the respiratory alkalosis is there, so body will try to manage this with the metabolic acidosis, and when the respiratory acidosis is there, so body will try to manage it with the metabolic alkalosis. So this is usually seen together. So, and we have to then, once we diagnose, then what is the acid base balance of the body, and then we have to manage that accordingly. To memorize this value, you may remember 24, 28, 4 difference, then 28, then one gap is 32, you forget that, then 36, then the one another gap 40, and then the 44. So gap of 4 may be the mnemonic you may set to remember it. After the assessment of the adequate tidal volume, minute volume using a spirometer, and then performing the arterial blood gas analysis for the acid base balance, and then we perform the capnography to monitor the partial pressure of CO2. If it is found to be inadequate, then there is the abnormality in the tidal volume, minute volume, or the acid base balance of the person. Then in those cases, we have to begin with the supplemental oxygen therapy using ambu bag and maintain the tidal volume at 10 to 15 ml per kg and minute volume of more than 4 liters per minute. Oxygen therapy is done to raise the partial pressure of oxygen to at least 45 to 50 mm of Hg. That is 6 to 7.3 per pressures. If even after supplemental oxygen with the ambu bag, if saturation is not improving, then we have to use the oxygen mask. In that case, we have to begin with the 28% oxygen mask. Depending on the response as assessed by the periodic arterial analysis, either continue with the 28% or progress to the 35% of the oxygen mask ventilation. If the condition is still not improving, then we should consider for the mechanical ventilation. Increasing metabolic acidosis with normal partial pressure of oxygen is highly suggestive of a poisoning case. It can be due to either toxins, a known poison, or the poisons that decreases the oxygen carrying capacity like carbon monoxide, and methemoglobinemia. So the list of conditions that causes methemoglobinemia are all will be showing the increased metabolic acidosis with normal partial pressure of the oxygen. Also, if there is reduced tissue oxygen like those in cyanide poisoning or hydrogen sulfide poisoning. The immediate need for assisted ventilation has to be assessed clinically, but efficiency of ventilation can only be gauged by measuring the blood gases. Retention of carbon monoxide, hypoxia, and despite the oxygen given by the mask is the indication. If the improvement is not there in the acid-base balance after all the measures, then the assisted ventilation is indicated. So retention of CO2 with a partial pressure of the CO2 more than 45 if it is continuing, and the hypoxia of less than 70 mm of Hg is the persistent despite the face mask ventilation, face mask oxygen, then we need to give the assisted ventilation to the endotracheal tube or tracheostomy tube. Then the next, after the management of airway and breathing, then there comes the management of the circulation of the patient. We already learned that what are the cardiac manifestation of a poison on a patient. Some poisons may cause the changes in the blood pressure, hypotension, hypertension, changes in the pulse rate, tachycardia, bradycardia, and the different types of arrhythmias and even heart blocks. So the clinical, we have to look for the clinical presentation of hypotension, hypertension, tachycardia, bradycardia, arrhythmia, and heart block. We already knew the different types of the poisons that produces those signs and symptoms, and when we were learning about the diagnosis of the poisoning, then we have to assess the presence or absence of the radial, femoral, and carotid pulses, and continuous cardiac monitoring using the ECG shall be done. Blood pressure we are looking, then the carotid pulses we are looking, and the continuous cardiac monitoring through the ECG lead shall be done. And if there is any abnormality, and accordingly we have to treat the patient as per the presentation. So if anything is inadequate, then according to the presentation, we have to secure the IV access. Then we have to manage the hypotension by IV fluid administration, or anti-dysrhythmic therapy shall be given according to arrhythmias. Then the vasoactive agents for the management of the bradycardias and heart blocks. Then consider for atropine, sodium bicarbonate, magnesium according to the condition. And then if still the patient is in deteriorated condition or in so cardiopulmonary resuscitation shall be given. We will be going in detail of these measures in slight detail in the next class. So with this, thank you so much for today. We shall meet tomorrow. Thank you.